Good morning, everyone. My name is Trish Zecca, and I'm a Senior Nutrition Program Manager here at IFINS, the Institute for the Advancement of Food and Nutrition Science. Today, I have the honor of moderating this webinar called What's New? Sodium Intake and Public Health Today. This webinar is first in a series of 7 free webinars and an invitation-only expert convening at the culmination of the series. The project is part of a broad IFINS effort to promote understanding of what's new about the many roles of sodium in diet, health, consumer preferences, food safety, and quality. This work was supported by the IFINS Sodium in Foods and Health Implications Committee. You can learn more about the series by visiting our website at ifins.org and then click on Sodium in the Food Supply webinar series. For those of you that are new to IFINS, we are a nonprofit organization that brings together government, industry, and academia to drive, fund, and lead actionable science in the areas of nutrition and food safety. We catalyze the creation of scientific knowledge and engage external researchers and convene experts to support change. Our collaborative and inclusive structure empowers others to bring forward the diverse perspectives of the entire food and beverage ecosystem. Now, before we get started, I'd like to cover how to ask questions. This is the first format that the attendees will see on their meeting interface. Starting at the top, you'll notice an orange arrow. This arrow allows you to expand or collapse the control window on your screen. When the window is expanded, you can type in your comments and questions. And in fact, this is how we encourage you to participate in the dialogue. The questions you type in are only visible to IFINS staff and not to other attendees. Some of you with a different version of GoToWebinar may see this screen. Again, you can type in questions where it has the question mark, and we will address those questions at the end of the webinar during the Q&A period. Also like to remind everyone that IFINS is a continuing professional education provider with the Commission on Dietetic Registration, CDR, and that this webinar awards 1 CPEU credit. A link will be shared to all participants after the webinar where you'll be able to access that certificate. So let's get started. Our first speaker today will be Dr. Robin McKinnon. Robin is a Senior Advisor for Nutrition Policy at the U.S. Food and Drug Administration, FDA Center for Food Safety and Applied Nutrition, or CFSAN. Dr. McKinnon works to advance FDA's nutrition policy initiatives across CFSAN, including those outlined in the White House National Strategy on Hunger, Nutrition, and Health. Prior to joining FDA, Dr. McKinnon was a health policy specialist at the National Cancer Institute, National Institutes of Health. At NCI, Dr. McKinnon led policy-relevant research activities on diet, obesity, and physical activity. She has a PhD in Public Policy Administration from the George Washington University and a Master in Public Administration from Harvard University. Welcome, Robin.
Great. Thank you so much, Trish. And thank you for the invitation to join today. As you mentioned, I'm Robin McKinnon, Senior Advisor for Nutrition Policy, and I'm thrilled to be able to present on an overview of our sodium reduction activities at the FDA and to present on behalf of so many colleagues. And I also note some of the key activities since the last IFANS meeting on this broad topic of sodium reduction since 2015. But a couple of things, the bottom line up front, as they say, some key takeaways. For me, the case for action since 2015 to help reduce sodium was already strong, very strong in 2015. If anything, it's even stronger now. And I would say also, secondly, there's now a variety of initiatives in place to help support limiting sodium intake, and that we may be starting to see some signs of progress in reducing sodium intake. So in terms of sodium intake, in a nutshell, we in the US, we still consume too much sodium in the US, around 3,400 milligrams per day. The upper limit is around 2,300 milligrams per day, which was reaffirmed by the National Academies of Sciences, Engineering, and Medicine, which issued a report on the DRIs for sodium and potassium in 2019, which affirmed this upper limit. In 2019, it was a chronic disease risk reduction level of 2,300 milligrams per day, so the level not to exceed in order to reduce your risk of chronic disease for those that are 14 years and older, and that's less than 2,300 milligrams per day for younger children. And so this chart was developed from the most recent dietary guidelines for Americans, and it shows population by age and sex, and everybody above 0, which is about 2/3 of the way down of the chart, that's in the hashed orange and blue, that's the percentage of the population exceeding recommended daily limits for sodium. So we vastly exceed still our limits for sodium. And the reason this is an issue is because of the impact and the link between excess sodium intake and hypertension and cardiovascular disease. So excess sodium increases your risk for hypertension and cardiovascular disease, and almost 47%, 46.7%, over more than 110 million adults in the US has hypertension, and African American adults are disproportionately affected, almost 60% of African American adults. Heart disease is the leading cause of death in the US, and heart disease and stroke together, cardiovascular disease, responsible for more than 800,000 deaths annually, which is worse than, to put it in perspective, than the awful toll of the COVID-19 pandemic in 2020 and 2021 combined. That was around 800,000 deaths. So that just in 1 year, cardiovascular disease is responsible for about more than 800,000 deaths. So something like 1 person in every 33 seconds in the US dies from cardiovascular disease. And then in addition to the health impact, of course, there's the substantial economic burden as well, so very costly from a healthcare perspective. And we know we do an annual survey or a regular survey at the Food and Drug Administration. We look at food safety and nutrition survey, and from 2019, we saw that almost half of the respondents reported watching their salt or sodium intake. So we know folks are paying attention to this or looking to, but when you look at where the sodium comes from in the US diet, it's somewhat different from other countries. Some countries, most of their sodium can come from the home, being added at home in cooking. But in the US, this is a study that was done published in 2017 by Harnack et al. And this was an update to a previous study from the 90s, Madison Donnelly, but looking at where our intake comes from in the US, and it's mostly from outside the home, from foods that's processed and prepared. If you look at the so 71%, the smaller slices of the pie in the pie chart there, added at home or added at the table, adds up to only about 11%. So it's been very difficult to help limit your sodium, even though people say they're trying to. With our current food supply, it's been very challenging to stay within the recommended limits. But we know the variability across similar foods and the food supply and an international experience, we can see that the reductions are possible. So the good news is that we can do something about it. And like I say, I think we're starting to see some signs of progress. So another thing that's different since 2015, many are no doubt aware, FDA issued voluntary draft guidance, short-term targets for about 163 categories of food, and that was finalized in 21, issued as draft in 2016. And that guidance was intended to support reductions to around 3,000 milligrams per day, which would still be an improvement, but is also still higher than even the upper level that's recommended to reduce your risk of chronic disease. And in issuing that guidance, developing the targets, carefully consider the role that sodium plays, because we know this broad, gradual effort is needed to help consumers limit their sodium intake. We know that sodium is an adaptive taste. We know that consumers' palates will adjust, but the change needs to be broad and gradual. So I thought I'd talk through an example in case folks are not aware of the FDA sodium reduction guidance. Of the 163 categories of food, they were broken into 16 overarching categories. And so just taking one of these 16 overarching categories, you see the bakery category here, in a number of subcategories, if you like. And within that, just looking at white bread, there's both a restaurant and a packaged food category there for targets. And then what you're looking at below in the bar chart is there was 308 products in that particular category. The red line showed the baseline or the average for the entire category in 2010. What we're looking to get to in 2024, by April 24, is in the green line there, that we're hoping to shift the whole category to the left, and that no one product would exceed the blue dotted line, which is the upper bound level. So that's an example of how the guidance works, looking at where, breaking the food supply into categories, looking at where everything is, and then providing specific targets for each category to meet. Another thing that is different is that in 2022, there was a conference held by the White House, a White House conference, and also a national strategy issued on hunger, nutrition, and health. And the conference was the second only conference of its kind in more than 50 years, with the goal of ending hunger and improving nutrition and physical activity by 2030, so that fewer Americans experience diet-related diseases like diabetes, cardiovascular disease, obesity, all while addressing health disparities and advancing health equity. And the national strategy that was issued is broken into 5 pillars here, with a variety of different actions to be taken across the federal government, across sectors of society, to achieve the overall goal. The FDA activities are mostly under Pillar 3 here, empowering all consumers to make and have access to healthy choices. And then within that, I wanted to highlight the initiatives within the national strategy that are supporting sodium reduction. And these can mostly be found on page 23 of the White House National Strategy. So focusing on sodium, it mentions that FDA will issue revised voluntary sodium reduction targets to facilitate continually lowering the amount of sodium in the food supply beyond the targets issued in 21. That will update regulations to enable manufacturers to use salt substitutes in standardized foods, that the VA will increase their lower sodium foods with regards to procurement, and also the Administration for Community Living, ACL, which is an agency within the Department of Health and Human Services, and that FDA will partner to provide technical assistance to help align the older adult nutrition program. So these are ACL funds the senior nutrition programs, such as Meals on Wheels. So millions of meals, nutrition assistance provided to our older adult population. And indeed, I'm showing some of those activities, some of those, the technical assistance, the toolkit that was provided in collaboration between FDA and ACL, and that's shown here. We also held a couple of webinars. In the national strategy, it says as well that the USDA will continue work to reduce sodium in school meals, consistent with the goals of the dietary guidelines, and also the FDA's voluntary sodium reduction targets. And you saw that in the bridge rule, or what was called the transition rule, issued in 22 for limiting sodium in school meals, and also in the proposed rule for longer term sodium reduction or limits within school meals as well. So there's a number of initiatives within the national strategy, and then also highlighting how FDA's activities are supporting the activities of other agencies as well. And just finally, I'll mention, in addition, the other activities that FDA we've been working on related to sodium reduction that help support sodium reduction. So in 2020, we issued a final guidance on an alternate name for potassium chloride in food labeling, for potassium salt, because we know that Potassium chloride, while not a perfect one-for-one replacement, it's a partial substitute can be a partial substitute for sodium in food technology. And potassium, the name may give consumers an indication that that is in fact a substitute for sodium and salt. And that part of our menu labeling requirements, that calorie information being required on menus and menu boards for covered establishments. In addition, upon request, consumers shall be able to ask for information, the additional nutrition information available in request, which should include the nutrition information. Sodium limits are also part of the proposed update to the nutrient content claim Healthy, which was issued on the day of the national conference, actually, in September 22. So sodium limits, as part of many updates in that proposed updates, there are sodium limits. And we've since announced that we're planning to work towards finalizing the Healthy update in the spring of this year. And then finally, we did issue a proposed rule on the use of salt substitutes in standardized foods. And that was in April of last year, proposing to allow safe and suitable salt substitutes in foods for which there are standards of identity, that where salt is or sodium is a required or optional ingredient. So with that, you can see, hopefully, there's been a lot of attention, a lot of activities to support reducing sodium across the federal government, across FDA, and as I say, I think we're beginning to see some signs of progress on that, but we'll be learning more about that in the presentations to come this afternoon and then beyond. Thanks so much, Trish. Back to you.
Thank you so much, Robin. I think that's a great setup for not only today's webinar, but for also the rest of the 6 webinars in the series that will be coming up this week. I'd like to take the time now to introduce our next speaker. We'll talk about the What We Eat in America survey, the complexity and challenges to assessing intake. And so our speaker will be Alana Moshfegh. Alana is the research leader of the Food Surveys Research Group at the Beltsville Human Nutrition Research Center at USDA. She leads a staff of nutritionists, food technologists, and statisticians in planning and directing a national program of research in monitoring food consumption behavior and assessing the nutrition adequacy of American diets. She's responsible for directing the What We Eat in America survey, the dietary interview component of the National Health and Nutrition Examination Survey. She oversees data preparation for public release, statistical reports and research papers, enhancements to national dietary data collection methodology, and develops nutrient databases of foods commonly consumed. For this program, she directed the development and validation of USDA's automated multiple pass system, a 5-step 24-hour recall used in What We Eat in America and in research studies in the US and internationally. She's participated in and established and collaborated with more than 30 studies, research organizations, and foreign governments regarding dietary collection data. Alana received her MS in Nutrition and Food Service Management from the University of Nebraska and her BS in Nutrition and Dietetics from North Dakota State University. She is a registered dietitian, member of the Academy of Nutrition and Dietetics, and fellow of the American Society for Nutrition. Welcome, Alana.
Thank you so much, Trish. Can you see my screen and hear me?
Yes.
Very good. I'm excited to be here at the launch of IFAN's webinar series looking at sodium in the food supply. And I'm so glad that this series is going to be held. Today, for my remarks, I'm going to talk about first starting with the challenges in estimating sodium intake in national surveys, and share with you the strategies we're using for keeping the database as well as the intake method current, and talk to you a bit about the resources that are available on the Food Surveys Research Group website. So you can look at these results as well as the data and the supporting resources that we use for national collection. There are so many challenges in monitoring sodium intake. And I've got a few of them listed here that you can see. Reformulations that go on of foods in the marketplace. We know those reformulations are going on to gradually reduce sodium. The variability of sodium within similar food types or brands. Currency, keeping current analytical composition data on the nutrient profiles of foods, not only for sodium, but for the other nutrients that we estimate. Participants' ability in our national surveys to report specifics about foods that they consume that will help inform us about the sodium content of the food, the exact kinds of foods that they are consuming. And that goes hand in hand with our data showing about a third, just under a third, of mean daily sodium intakes come from foods outside the home, restaurants, fast food establishments, and other away from home food sources. And of course, there are many other challenges, but this gives you at least a sampling of what we worry about, try to keep track of as we're looking at collecting national dietary data. So now I want to move into and talk a bit about the method. You have now what are some of the challenges, and as I'm talking about not only the method but the database, I want you to keep in mind those challenges. So within our NHANES survey, the dietary data, we collect 2 24-hour recalls. These are collected through interviewer administration. The day one has been in person from 1999 to March of 2020. Then NHANES was paused because of COVID. It restarted again late in 2021 with collection for both days, both in person, both days, day one and day two, by telephone. The telephone for day one now is done, and about 3 to 10 days later, we have telephone for day two as well. The next NHANES will begin, is scheduled to begin in 2025. And again, both of the days of recall will be done by telephone. We use trained dietary interviewers who are bilingual in both English and Spanish. The recalls are conducted all days of the week, and the method that's used is USDA's automated multiple pass method. And you can see the graphic of that on the right hand of this slide. It goes through 5 standardized steps. The method has about 27,000 questions and response options for the foods and beverages that get reported in the survey. Now, for these extensive number of questions and response options, we periodically update every 2 years to keep current with the food supply, as well as what we know our participants are having challenges with in answering questions. And I'm going to talk quite a bit about that in the remaining slides. The method's been validated for energy as well as for sodium. And let me share with you our validation study that was done in 2002 to 2004 on a very large sample of healthy weight-stable adults, over 500 of them from the Washington, D.C. Metropolitan area. We did 3 24-hour recalls on these individuals using the AM/PM. We dosed them with doubly labeled water over a 14-day study period, did the recalls over those 14 days, as well as, in addition to collecting spot urines, we also collected 2 24-hour urine collections. The results showed the validation for energy. Energy intake overall was underreported by 11%, but was practically spot on for normal weight. And the next slide will show you the results for sodium. So we compared 2 24-hour urine collections that were done on the same day as 2 24-hour recalls. And the reporting accuracy for the AM/PM method for sodium was 93% accurate for males and 90% accurate for females. So this validation study established that the AM/PM is a valid measure for estimating both energy and sodium for populations or groups of individuals. So we're starting with a methodology that is quite valid. Now, in addition to the AM/PM method, the other pillar for national dietary surveillance is the database that characterizes the nutrient content of all the foods and beverages that get reported. And that's the Food and Nutrient Database for Dietary Studies. It's an application database that goes hand in glove with the AM/PM. The foods and beverages in FNDDS are based on the AM/PM questions and response options. So FNDDS is designed to support the AM/PM. It gives you all the foods and beverages that get reported in What We Eat in America, as well as the portions, and converts those portions into gram weights. The nutrient profiles for all of those items are based on the values that are in USDA's Food Data Central, a relatively new composition platform that sits on the internet and is accessible to anybody. We update FNDDS just as we do AM/PM every 2 years based on updates to the AM/PM as well as updates to FDC. Now let me talk about a bit more detail on the strategy of the updates, both for the AM/PM and for FNDDS. I talked about there's 27,000 questions and response options. We've structured those into about 130 groups of similar foods and beverages. We review and update the questions and the response options between about 5 to 10 of these groups every 2 years. We focus these reviews on a number of things, and I've shared with you here on the screen what some of the more prominent things we look for as we're reviewing a category and the questions that we ask, as well as the database. And you can see we look at sodium, major contributors for selected nutrients, one of them being sodium, as well as a number of other options. Looking across the category for foods that are home prepared versus ready to eat or ready to heat from a restaurant or fast food. Now, to give you the extent of the updates that go on for each of these 2 years, I've shown you the categories that have been updated for the past 3 survey cycles within the AM/PM as well as the FNDDS. And these are detailed and documented in the database for and the documentation for the FNDDS. But you can see the large number of categories that we are going in and looking at, not only the questions in AMPM, but the nutrient profiles for the foods that fall within these categories. Now let's jump to FNDDS. The nutrient values for about a third of the foods in FNDDS are based on one Food Data Central code. The remaining 2/3 of the foods, the nutrient values are generated by FSRG nutritionists using a recipe calculation process. And we do those for home prepared dishes, for various cooked meats, eggs, grains, and vegetables that consider salt and/or fat that's used in preparation, as well as for processed and restaurant foods where there is no appropriate FDC data. We look at the websites of the food industry, cookbooks and recipe websites, as well as another data type on Food Data Central, the Global Branded Food Products Database, to get an idea of what should be the ingredients and what should be the amounts. The yellow blocks on the side shows you for FNDDS 1920, all of the foods, a little over 5,600 of the foods that sit in that database. We populate the nutrient profiles based on about 1,800 Food Data Central nutrient profiles. Majority come from SR Legacy, but more and more, as we get more foundation foods, another data type that sits in Food Data Central that has more updated analytical data, we are using those as well. In the FNDDS documentation, we provide the source for each nutrient value for each ingredient. And if the nutrient value is adjusted or modified, we provide the details of where we got the modification and document that source. So there's an extensive background of getting at these nutrient values. And that's necessary because we know these values are changing. A few other important points on this recipe calculation process. The FNDDS nutrient values represent an average of variance of a food or beverage, not an exact product. FNDDS foods do consider salt and fat used in preparation and may be included as an ingredient in its profile. Each ingredient for salt or fat does not imply in this recipe that these are actually ingredients in the product. Salt or fat may be added in the recipe calculation process to represent a nutrient profile. In the yellow box, I'm showing you a question that's asked within What We Eat in America NHANES. How often is ordinary salt or seasoned salt added in cooking or preparing foods in your household? And you can see about 3/4 of the respondents from the latest data that's been released are saying they occasionally or very often are adding salt in preparation. That isn't to say, though, that we don't have foods in FNDDS that are lower or reduced sodium options. It includes reduced sodium options for several foods, and I've listed those broad categories. So when you go into FNDDS, you can see these in the database. Now I want to just share a bit of what the data looks like in terms of sodium. I'm cautiously optimistic. I've shown you 3 points in time. The one at the far right is the most current. And you can see we are slightly, on average, decreasing our sodium intake. I'm cautiously optimistic, and we're so looking forward to seeing the 21-23 data to see if this trend of going down is increasing. When you look at daily averages per 1,000 calories, we see that decrease continuing. Now, this is our website and where you can get most of the information I've shared with you today. If you're not on our listserv, please go to it and sign up. And in summary, I've given you the mean daily sodium values of just a little over 3,300 milligrams. Males 30 to 39 have the highest sodium intakes. We know we're exceeding, both for males and females, the recommendation of no more than 2,300 milligrams. Updates and enhancements are being addressed both in AMPM and FNDDS to augment population-based dietary data collection and to focus on food supply and market changes. Sodium is a major focus of these updates. Thank you so much for your attention, and I look forward to the question session. Thank you.
Thank you very much, Alana. There's so much that goes into it. I really think it shows the complexity of how we measure dietary intake of sodium. So our next speaker is going to be Dr. Mavra Ahmed. Mavra is a research associate at the Department of Nutritional Sciences and Johanna and Brian Lawson Center for Child Nutrition at the University of Toronto, and she's also an adjunct professor at the Ontario Tech University. She has expertise in both food and nutrition policy, and her research focuses on driving equity-focused policy shifts by determining the relationships between determinants of health, dietary pattern intakes, and nutrition-related behaviors and knowledge to improve the health of vulnerable populations, particularly children and adolescents and those in racialized or marginalized groups. Mavra obtained her PhD from the University of Toronto, specializing in characterization of dietary assessments of Canadian Armed Forces and evaluation of novel technologies for dietary assessments. She is also a CIHR Fellow in the Strategic Training Program in Public Health Policy and a Fellow in Artificial Intelligence for Public Health from the Dalla Lana School of Public Health. Please welcome Mavra Ahmed.
Excellent. Thank you so much for that introduction. Trish, can you hear me okay? Great. Okay.
Yes, we can.
Great. So good afternoon, everyone. And I'm really excited to be part of this webinar series. And thank you for giving me this opportunity to talk about my findings on the broader dietary value of our top sodium contributors. So with that, we'll get started right away. I'm not going to belabor this point. We've seen this in previous slide. We know that nearly 9 out of 10 Americans consume sodium at levels which exceed the amounts recommended by the dietary guidelines for Americans. Therefore, reducing population level sodium intakes can help us also achieve reductions in blood pressure, which is an important preventative strategy to lower the risk of cardiovascular diseases, knowing that it's the leading cause of death in the United States. And it is well established that dietary sodium is derived from prepackaged foods, and that what we really need to do is that there have been efforts to curtail this population sodium levels through consumer education and food labeling campaigns. But now we want to understand this need to create healthier food environments so that consumers have access to adequate selection of lower sodium options. So really, in order to do that, we want to understand first, what are those top sodium contributors to the diet? And what are they for specific sociodemographic strata, and are they different than what they used to be compared to previous research that has been done? In addition to those elevated sodium levels, we also know that intakes of several nutrients such as vitamins A and E and C, folate, magnesium, iron for females, for example, are inadequate relative to the recommendations. And in line with the dietary guidelines, other shortfall nutrients such as fiber, calcium, vitamin D, and potassium are still considered quite important for Americans given their underconsumption and how that's been linked to adverse health outcomes. So now we want to really understand, what if the top sodium contributors are also perhaps potentially important dietary contributors to other key nutrients and food groups? And what does that really mean for diverse population groups? So with that, I'd like to present my research objectives, where we really looked at assessing the top contributors to sodium intake. We needed updated data on these top food category contributors, given the need for continued prioritization of sodium strategies for the population, and furthermore, to determine those nutrient and food group contributions to the diet from those top sodium contributors. But the other thing I want to note over here is that we also looked at these top sodium contributors as well as the nutrient and food group contributions for specific sociodemographic strata by age, sex groups, ethnicity, and poverty income ratios. So this study was a cross-sectional analysis of the nationally representative data from NHANES from 2017 to 2018. And full nutrient and dietary data were available for about 7,640 respondents, where we excluded children under the age of 2 years old, as well as lactating individuals were excluded from the analysis, leaving a total sample size of 7,081. For analysis across household income subgroups, there were a few more that we excluded due to missing income data. And really to inform our equitable approaches to support healthy eating for all Americans. As I mentioned earlier, analyses were completed for the overall populations and by dietary reference intake age sex groupings as listed right here on the slide, as well as by the ethnic groups that were defined as per self-reported data collected at NHANES. And household income groups were defined using the poverty income ratio, which represents the ratio of household income to the federal poverty threshold. And they're grouped according to the cut points as listed right here. Okay. In terms of our food categorization, so we use the USDA food composition database, food and nutrient database for dietary studies to determine the amount of sodium in foods consumed by the respondents as they reported in their 24-hour recall. And we also use this database to define the food categories, which were aggregated into 87 categories adapted from the What We Eat in America food categories. And what then we did was looked at the percent contribution of each of these food categories to total daily dietary sodium intake using a population ratio approach in which essentially we sum up the sodium intake across all individuals in the sample and then divide by the sum of total daily intake of sodium for all individuals in that particular sample. So this approach is consistent with methods that had been used previously as well. All right, so diving right down deep into our results. First, I want to highlight, we looked at the top 10 sodium containing food categories, which represented or contributed about 40% to total dietary sodium intake, and were mostly consistent across those different subgroups that I had mentioned earlier. But when we looked at these top 10, we started to think about this data a little bit more, and we were like, okay, let's consider other top sodium contributors, perhaps those that contribute meaningfully to total sodium intakes in key subgroups. And then we started to investigate it by those DRI age sex groups as well as by ethnicity and poverty income ratio. And then we also wanted to look at these food categories that were consistently observed perhaps across these different subgroups or were observed as contributors for majority or priority subgroups. As an example, chicken nuggets, for example, was ranking in the top 10 for children and ranking in top 15 for low-income groups. Again, there were some anomalies that we came across where food categories perhaps ranked in top 10 for certain subgroups, such as rice, which was ranking as the second highest contributor to sodium among Asians. But overall, what I'm showing to you right over here is essentially the selected top 15 food categories that are contributing about 51% to total dietary sodium intake. Okay, so that's all great. So we have our top contributors of dietary sodium, but as I mentioned earlier, what if they're also contributing to key nutrient and food groups for the overall population or for certain subgroups, right? So now we really want to understand this a little bit better. In order to do this, we continued with our analysis, and the nutrients chosen for this analysis were those for which there is known suboptimal population intake or intakes that exceeded perhaps recommended level, as well as those of interest based on the usual composition of foods determined previously to be the top contributors of sodium. So in this case, we investigated the following nutrients, including energy, saturated fat, total and added sugar, fiber, protein, folate, vitamin D, calcium, potassium, and iron. And we also used a population ratio approach to do so for this particular analysis. Now, at first glance, this data is very heavy. There's a lot going on this slide, but taken together, what we saw was the major dietary sources of sodium are contributing to dietary intakes of nutrients of public health concern, of course, with considerable variation by food sources, as well as by those subgroup analysis. So I'm gonna now take this slide and break it down a little bit more for you so you can really understand the message behind this. So let's look at this. This particular slide is showing us the top 15 food category contributions to positive nutrient, where the green stars, as highlighted on the slide, indicate the top sources of these particular nutrients. So as an example, bringing right over here, we have breads, rolls, and buns, which are contributing, for example, folate and fiber to the diet. Another example are vegetables, which are considered to be the leading sources of potassium, and cheese, right over here, considered to be a leading source of calcium. Similarly, we did the same for the percent contribution of those top sodium contributors to nutrients that we should limit. And you can see right over here what's happening. So as an example, cookies, cakes, for example, are contributing to calories, as well as sugar levels. And over here you have savory snacks, which are contributed considerably to calories as well. You have your cheese that are contributing to saturated fat. But what about the same data in terms of these high sodium containing foods and what they contribute in terms of nutrients by certain subgroups? So I'm not going to showcase all of the nutrients in the interest of time, but I want to give a little bit of sort of an idea of what is happening over here. So what we see on this particular slide is the percent contribution to folate by poverty income ratio. And you can see that folate consumption, particularly from breads, for example, and vegetables, tended to increase from lowest to middle to highest household income status. Again, this particular slide is showing the percent contribution to added sugar by poverty income ratio of those top sodium contributors. And you can see that middle income households derived more added sugars, perhaps from bacon, frankfurters, and sausages, as well as for cold cuts, as well as for soups compared to other income groups. This particular slide is focusing on fiber by ethnicity. So you can see that Asian Americans are deriving a greater proportion of their total fiber intake from breads, perhaps. The data is quite consistent across the different ethnic groups for vegetables. So these are the type of results that we're seeing for fiber. Over here, you can also look at iron. Again, Asian Americans are deriving a greater proportion of their total iron intake from breads. And again, the data is very similar to vegetables, but a little bit higher for Asian Americans. And over here, you have Hispanics who are deriving a lot of iron from the burritos and tacos. Similarly, this is data for potassium, the percent contribution to potassium by the top sodium contributors by DRI age sex groups. Over here, you can see for females, perhaps, as well as for females aged 19 to 50 and females also aged over 50, we are seeing them getting a lot of potassium from vegetables. And this data is for saturated fat by DRI age sex groups. So again, there are a couple of different age groups deriving levels of saturated fat from some of those different top sodium contributors to the diet. So far what I've shown to you are the nutrient contributions coming from those top sodium contributors. But now let's think about what about the food group contributions, right? So we also looked at examining the top 15 sodium contributors for their dietary contribution to food groups of public health concern, which included fruits, vegetables, dairy, grains, protein foods, and oils. And in order to do that, we continued with our analysis using the individual food files that are available in NHANES to do so, as well as looking at the episodic consumption of some of these food groups in order to apply appropriate statistical methods to analyze this data. Again, diving right down into what the results are. And there's a lot happening over here, but essentially we found that the contribution to food groups that are consumed varied considerably across those different categories. So I'm going to try to break this data down again, and I'll do so in the form of a story. So let's think of pizza. Now, overall, bringing sort of all the results together and really showcasing to you what's happening, we know that pizza is consumption was lower in older adults compared to younger adults, as well as children, adolescents, and it was also low in higher income participants. And the nutrients that pizza provided were moderate amounts of iron, folate, and calcium, but it also contributed to calories, saturated fat, and sodium. But in terms of food groups, you can see it was providing about 42% of 1.5 cups of vegetables that were consumed, which is translating to about contributing 21% of recommended intake of vegetables right over here. So again, the data I'm showing right over here is in relation to the number of servings that were consumed of different food groups. So 55% of the 1.63 cups of dairy that was consumed was coming from pizza, as well as 48% of the 6-ounce equivalent of grains were being contributed by pizza, and oils. Pizza was contributing about 41% of the 29 grams of oils that were consumed by the population. So for continuing on with a few more examples to really understand this data a bit better, cold cuts, a high proportion of males 50 plus consume cold cuts compared to the other age and sex groups. They were highest in white and lowest in Asian, the consumption, and also low in higher income groups. Cold cuts provided low amounts of positive nutrients, but ranked in the top 10 as a sodium contributor. And again, with food groups, 41% was coming of protein was coming from the cold cuts. And lastly, for cheese, very similarly, you see that cheese provides high amounts of calcium and vitamin D, but also contributes to saturated fat and sodium. And it was contributed significantly in terms of dairy consumption. So overall, just to summarize very quickly, you see that the different, I'm getting a little bit of feedback, sorry about that, but I'm almost done. So overall, you can see the different top sodium contributors were providing anywhere from 40 to 50% of different food group servings, which were contributing anywhere from 10 to 35% or 40 to 50% of recommended intakes, depending on the recommended intake for those particular food groups. And the results were quite similar by ethnicity, poverty income ratio, and age sex groups. There were a few differences, for example, but overall, there were quite consistent results. So in conclusion, the key points I want to take away from today's presentation is that the top 15 food category contributors to dietary sodium represent just over 50% of total dietary sodium intake for American adults. We also see that results are showing us that many top food category contributors to sodium intake, such as vegetables, cheese, cold cuts, and breads, are also important contributors to shortfall nutrients, as well as food groups of public health concern. But these food categories at the same time can also be major contributors to nutrients to limit. And some of them perhaps provide little to no contribution to intake of other nutrients or food groups. Keeping in mind that the variability in the ranking of categories contributing to sodium intake by different subgroups, age, sex, ethnicity, and poverty income ratio are likely a function of broader social, economic, and environmental factors that play a role in our food choices and dietary habits. So for example, pizza is perhaps quite popular among adolescents, and there are other sort of choices also, for example, our health concerns or education and health literacy, the incorporation of ethnically diverse or traditional foods, and food availability and accessibility also play a huge role. And lastly, studies showed how sodium contributors impacted nutrient and food group intakes across those different sociodemographic strata. So we really want to think of sodium reformulation efforts to be broad and to target all food categories so benefit can be had amongst all diverse diets. And with that, thank you very much.
Thank you very much, Mavra. I appreciate it. And it really has given us a lot to think about in terms of what the messages should be around sodium and foods, maybe not necessarily to avoid, but how to make those high sodium foods that are positive contributors to the diet lower in sodium so people can still enjoy them. But I'd like to invite the rest of our presenters to join us for a quick Q&A. We only have a few minutes, so I want to make sure that we get to the important questions. So Robin, I just want to address the first question to you. There was a question related to when the proposed rule for the standards of identity is expected to be finalized, and how will the success of those initiatives be measured, since it takes a long time to measure sodium in the food supply. So what are the other ways that you'll measure success?
Right, and thanks Trish for the question. And so just quickly on the salt substitutes proposed rule. So the comment period for that ended only towards the end of last year. It was August of last year. So it's very typical for it takes some time to go through the comments that were received. So we're in that period right now of reviewing the comments, and then so we'll be considering all of those. And then so it's bottom line is it's too it's too soon to say yet on timing for finalizing, which is always challenging given it includes a range of different factors. And in terms of metrics or monitoring, colleagues here, Alana, Mavra, presented on some of the metrics. We're also, so there's a range of different ways we can be measuring the changes in the food supply and the changes in intake and the health outcomes. But one thing I also want to reinforce is that the efforts that I've outlined here and across the federal government are part of a much broader set of activities. So part of the White House National Strategy, really this whole of government, whole of society approach. So there are a number of individual initiatives that are in turn embedded in a much broader whole. Thanks.
Thank you. And then this is sort of a compound question, and it'll have to be our last question of today. One attendee responded that they've seen a surge of electrolyte drinks and drink mixes, especially high in sodium, higher than typical sports drinks, and being marketed to all consumers, not just athletes with higher needs. So if there's any particular comment about those drinks, but even more important, what type of educational initiatives are happening, not just for consumers, but also for, what about training for chefs about using alternatives, in cooking? Because some of this work, as we'll see in some of the webinars that are coming in the series, food companies are addressing sodium, but what about chefs in like food service, production, and that type of thing? Are there any educational initiatives being directed at them?
I can share very quickly that yes, we've been collaborating, we've been talking to the Culinary Institutes of America, presenting on webinars with those. So it's an all of the above approach. I don't feel like it's any one thing that the efforts to, and it's not only just any one food that because if it's consumed infrequently, that's the beauty of a broad, gradual approach to help address the entire food supply, because some foods may be not quite so high in sodium, but they're consumed very frequently. So therefore, it's also important to be reducing sodium. So it's just tailoring approaches and working through as many avenues as possible. Education is certainly a key component. So are many of the initiatives that I mentioned earlier as well.
Any final comment, Mavra or Alana, related to some products that you might be seeing with excess sodium?
I could just add to it. I think it's also important to keep in mind the sponsorship or endorsement of those electrolytes when it comes to partnerships with fitness or sports organization to really raise the awareness, and also perhaps nutrition literacy in school and college programs, I would say.
Well, thank you so much. So that's all the time that we have today. I just want to, again, thank all of our presenters, encourage those in attendance to check out some of the other webinar topics in the series. Education and future initiatives will be addressed in some of those webinars, so some of your other questions will be answered. And I encourage you to connect with IFINS. If you have questions, you can send them directly to me, trishbeck@ifins.org, or you can connect with us on our website or through our LinkedIn. So thank you again, everyone, and have a great day.
Thank you. Bye.